Okay, good afternoon. I'm specialized in neurology and Parkinson movement disorder. So today I will spend about 1.5 hours to give you some introduction about the clinical feature of the Parkinson disease, and also the current research update on the genetic research, and also part of my research in the past 10 years. So this is today's outline. A neurologist, we see a lot of patients with neurological symptoms and signs, including the stroke, epilepsy, headache, and some population is neurodegenerative disorders, including the, I think all of you may know the Alzheimer's disease, dementia, and also the Parkinson's disease, and some other movement disorder. And we also take care of some genetic disorder. Those patients may affect the nervous system or functions. So those patients will come to my clinic to see for help. This is the global burden of disease according to the recent update, 2019. You can see the neurologic disorder is in the 10th burden of the disease. And we take a look about the neurological disorder. The Parkinson disease is about also the 10th more important disease causing the global disease burden in the neurological disorders in the global population, and also in many developing countries, also the developed countries. And this is another statistic about the region. Different region, they have increasing number of neurologic disorder with age, with aging society, especially in the highly developed countries. We can see the Parkinson disease, the patient number growing from the 1990 to the 2019, increase about 2% or change. This is a case scenario of Parkinson disease. The Parkinson disease, I think maybe some of you may know the tremor. The tremor is an easily seen feature of the Parkinson disease, but not all the Parkinson disease patient has tremor. About 70% patient, they have tremor. So this is a case scenario. We show you a 56-year-old man presenting with tremor of the right hand when put on table or holding cup for 5 years. So this is a slowly progressive disorders, and sometimes the initial symptom is very, very subtle. You cannot clear cut. So when the disease started. And also the patient developing the increased difficulty of doing some fine work, especially like the short button and handwriting become smaller like this. So this is a typical feature of the Parkinson disease. Parkinson disease in the aging population is the second most common neurodegenerative disease following the Alzheimer's disease. The prevalence in the elderly population is about 1% in the age greater than 65, increasing to the 3 to 4% in the age over the 80s. The lifetime risk of developing the Parkinson disease is about 1.5%. And there's a little gender difference. For Alzheimer's, you can see the women a little more than men, but the Parkinson disease, the men is about 1.4-fold than the women. Why the Parkinson disease called Parkinson disease? This is because in 1817, there's a London doctor, James Parkinson. He wrote a book called Essay on Shaking Palsy. at that time, because the highly industrialized society, so London, in London, there are many population immigrant from other area. So he observed 6 patients presenting with the figure, when walking with the stupid posture, and also walk slowly, and the limb cannot shake, or limb shake too much. So after the 15 years later, the French neuropathologist Jean-Martin Charcot, he used his name to name this disease. So that's why we call it Parkinson disease. The motor manifestation of the Parkinson disease, there's 4 motor manifestation. This cardinal manifestation is TRAP, T-R-A-P. Tremor means tremor, rigidity, and slow movement. We call it kinesia, or bradykinesia, and postural instability. So let's take a look on the video. So in the left up, you can see the tremor. Left lower, you can see the hand tremor, like this. And this is the slow movement. You can see the right side hand movement is slower compared with the left side. And in advanced stage, the PD patient can presenting with postural instability and some gait problem. This patient is when I was in the Kingdom of Eswatini, Southern Africa, I think last year. I saw a patient in the Kingdom of Eswatini. So what is the pathology of Parkinson disease? There's 2 cardinal features. One is neuronal loss. The other is Lewy body. Is intraneuronal eosinophilic inclusion body. The neuronal loss is present in the substantia nigra pars completa. The mainly is the dopaminergic neuron. About 50 to 60% of dopamine neuron loss, the patient will get developing the symptom of Parkinson movement disorders. And the other feature is Lewy body. The Lewy body is a eosinophilic intranuclear inclusion body. It's alpha-synuclein positive. So that's why alpha-synuclein we think is one of the important marker of the Parkinson disease. And so the dopamine deficit can cause the neural degeneration and also the neural circuit change, and decrease the motor circuit output. So in our basal ganglia control our normal movement by these structures. When we have a motor command, there's a GABAergic synapse to the striatum. The striatum is controlled by the substantia nigra pars completa dopaminergic neuron. There are two receptors. One is D1 receptor and the D2 receptor. The dopaminergic neuron activate the synapse activate the D1 receptor. Then the D1 receptor active. There's a GABAergic synapse to the GPI. So finally, the thalamus get the output to the motor cortex to control the movement. The other is the inhibition of D2 receptor. So this those two, D1 and D2, and the direct and indirect pathway, they keep a balance between them. When the dopamine neuron loss, you can see the dopamine D1 stimulation is decreased. So GPI SNR inhibition is decreased. So this GPI and SNR increase the inhibition to thalamus. So finally, the thalamus to the motor cortex is input is decreased. So finally, the motor output is decreased. So this is the motor circular basal ganglia. So we can supply the dopamine here to replenish the dopamine deficient, and also we can stimulation the GPI to inhibit the signal output to thalamus or to stimulation the subthalamic nucleus to decrease the input to GPI, to decrease the inhibition to thalamus, to normalize the motor signal to the motor cortex. So that's why we can use both the medication or use the deep brain stimulation to treat the patient. We have a special talk in October 2nd. Professor Benaggio will show you the history of research on the deep brain stimulation. And we diagnose the Parkinson disease according to the diagnostic criteria developed by the UK Biobank and also by the Movement Disorder Society. There's a mandatory criteria. Bradykinesia is the most central part, including the chest tremor and the rigidity. And the supportive criteria here. So the patient should be, it's better to have a good response to levodopa or dopaminergic therapy and the resting tremor of one limb and slowly progressive, and it should not have the some exclusion criteria. This is because the Parkinson disease, there are some disease like Parkinson plus syndrome, they also presenting the TRAP trap symptom like the Parkinson disease. But the pathology and the underlying pathophysiology is different. Those Parkinson plus syndrome, we call it a typical Parkinsonian. Those are progression greater and also has more other symptoms besides the motor phenotype. So the typical Parkinson disease is account for about 60 to 70% of the patient presenting with TRAP. But there still have some patients presenting with TRAP, but they are not Parkinson disease. They are atypical Parkinsonian. Those conditions can be a Parkinson plus syndrome. It means the patient has a Parkinsonian TRAP symptom and also other symptoms added. For example, like the multiple system atrophy, the patient also have the autonomic dysfunction and also can have the cerebral ataxia, cerebral degeneration. And for the progressive supranuclear palsy, those patients, besides the Parkinsonian, they also have the vertigo gaze palsy and apraxia and high cortical function problem. And for the dementia of Lewy body, those patients has profound dementia. So those patients are different from the typical Parkinson disease. The underlying pathology and the pathophysiology are also different. And they also have some secondary causes. So when we see a patient, we need to know there's a typical feature and also know the atypical feature to make a correct diagnosis. Because those patients, typical and atypical, those progression and different, and the medication treatment response are different. So how can we make a good diagnosis? Actually, nowadays we diagnose Parkinson disease largely by the clinical feature. We have some supported neuroimaging tool to for the assisted diagnosis of Parkinson disease and Parkinsonian. One is dopamine transporter image. Dopamine transporter image is now is widely used in Taiwan and several countries. This is because our dopaminergic neuron, the nerve terminal, there is a structure called a dopamine transporter. So when we neuron release a neurotransmitter, the transmitter released by the downstream receptor. Those neurotransmitter can recycle back through the dopamine transporter. So dopamine transporter only expressed in dopaminergic neuron. So this can be used as a good marker to reflect the dopamine neuron loss because it's only bind to dopaminergic nerve terminal. So now we can use the dopamine transporter image to see is there dopamine neuron nigrostriatal dopamine neuron loss. So like this. So this is a CHODET image. You can see the normal like this. This is a PD patient. You can see the decrease of the dopamine transporter, the reuptake of the CHODET signal. And also we can use the brain MRI. But brain MRI, actually we use brain MRI to exclude other disease other than the typical Parkinson disease. For example, the multiple system atrophy, we can see the cerebral atrophy. And also we can see the Ponting atrophy. The Ponting atrophy can presenting like the specific figure like this. This is a hard cross-bond sign. And also in the progressive supranuclear palsy, those are not typical PD. This is because of tau protein problem. So you can see the atrophy of the midbrain compared with the pons. So it looks like the penguin. So you can see the brain images are different. And also in the vascular Parkinsonian, you can see the white matter change, the small vessel disease, and this is normal pressure hydrocephalus. So those patients can presenting slow movement, rigidity, kinesia, postural instability, very similar to the Parkinson's disease, but they are not Parkinson's disease. So those patients may not have benefit for the levodopa or dopaminergic therapy. So regarding to the treatment, medical treatment, before the 1970, they are not good. There are no good medication. This is an older movie in 1990. Maybe some of you may have seen this movie, The Awakening, cast by Robert De Niro and Robin Williams. So this is a true story by Oliver Sacks, written by Oliver Sacks. So the story is talking about a disease called encephalitis lethargica. Encephalitis lethargica is a virus infection in around 1920 to 1930. That time the pandemic caused many people deaths, but there are some patients survive with the severe disability, like the left side, the patient cannot move, just like cannot move but those patients gave the levodopa, the patient can stand up and dance. So this is because the encephalitis lethargica, those virus kill the dopaminergic neuron very severely. So those patients have response to levodopa. So that's why levodopa is effective for dopamine neuron loss patient. But the developing of the levodopa therapy, there are several contributor. One is the R.B. Carson. R.B. Carson, he won the Nobel Prize in 2000. He found dopamine is a neurotransmitter in the brain. and the PD is related to the dopamine in the brain. And the other two, Honey Kiwis and George Cotius, those two doctors, they did the clinical trial for the levodopa treatment in Parkinson's disease patient, and they found the success. So that's why nowadays we still use the levodopa therapy for Parkinson's disease. Regarding to levodopa therapy in Parkinson's disease, there are two Nobel Prize. One is I have mentioned the Professor R.V. Carson. R.V. Carson, he found the neurotransmitter of dopamine, and dopamine is very important for Parkinson's disease. The other person is William Noll. William Noll, he is a chemist. Why I show this person because he made a very important discovery to convert the chemical to the erophone. We know in the biological environment or in the pharmaceutical, the erophone is active form. Erophone is active form. So how to convert the chemical efficiently to erophone is a good business to you can make a lot of purified drug, purified compound, and active compound through the chemical reaction. So we didn't know he won the Nobel Prize in 2001 in the chemistry. So he is because why we use levodopa, not use dopamine to treat the Parkinson's disease patient. Why we use levodopa? This is because of dopamine deficit. Why don't we use dopamine for the patient? Anybody knows? Okay, this is because dopamine is polar structure. Dopamine cannot penetrate through the blood-brain barrier to enter the brain. So we need a prodrug. The prodrug is levodopa. The levodopa can enter the brain through past the blood-brain barrier, then enter the neuron. In the neuron, there's the dopa can convert to dopamine. So that's why we use levodopa to treat patients, not to use dopamine. I think you may know dopamine we use in the ICU, the resuscitate patient to increase the blood pressure. But dopamine is not acting centrally. So we use levodopa to treat patients. So for the treatment of the Parkinson's disease, the mainstay is the levodopa. But there are still many medication developing in the past 50 years. So we can supply the deficient dopamine, and we also can use some medication to acting on the postsynaptic receptor. So that's why there's some medication developing the dopamine agonist acting here. And we also use some medication to lengthen the synaptic state of the dopamine. So we use the COMT inhibitor or NLB inhibitor. Those two inhibitor can increase the synaptic level of the dopamine. So the synaptic transmission can be more efficiently. So that's why we use those medication to treat the patient. But unfortunately, when we use the levodopa therapy in long term, they can develop some motor complication. One is the wearing off phenomenon. So the other is levodopa-induced dyskinesia, like the Michael J. Fox. I think maybe some of you know this great actor. He played the cinema Back to the Future. Remember? I don't remember. You are too young. Maybe 30 years ago. Yeah. So unfortunately, when we use the levodopa, initially they can get a good response to the motor improvement. But in long term, because of the levodopa, the dopamine neuron loss gets less and less. So the therapeutic window gets smaller and smaller. So when you give too much levodopa, there's a surge. The patient presenting with levodopa-induced dyskinesia. But when the dopamine level drop, when the levodopa level drop to a certain level, the patient became freeze. So this on-off phenomenon and levodopa-induced dyskinesia, those are the two unmet need in clinical treating the Parkinson's disease. So the other way is we can use the deep brain stimulation to bypass the dopamine controlled pathway. This is one of my patient. He received the surgery, I think 4 years ago. Before the operation, he difficult to move. But after the operation, he can walk. Yeah. For the surgery, we need to have good collaboration with the neurosurgeon to perform the surgery. We insert a small electrode to the subthalamic nucleus and connect to the control the battery and the impulse generator in here, put here. And we can record the brain signal when we do the surgery to make sure we put the correct direction, correct place of the subthalamic nucleus. So this is this the same person. Just show you after the surgery, he has dramatic improve his motor symptom and the quality of life. And however, the Parkinson's disease is still a neurodegenerative disease, so it definitely progression following the time, but not the same in any in patient. Some patient may progress slower. Some patient may progress a little faster. So this is we approximate for the 7 years. We call it early stage Parkinson's disease. During this stage, the patient he take the medication. They can do the usual work. And the daily activity is not affected by the disease. But in the middle stage or late stage, the patient can have some addictive symptoms. The patient can have the motor fluctuation, like I have shown you the on-off phenomenon, and also levodopa dyskinesia, and also the patient can have some non-motor symptoms, for example, like the cognition problem and also static hypotension and the urinary symptom. Those conditions can severely affect the quality of life in Parkinson's disease. So we have think to how we can treat this disease and how we can help the patient. So we have to know the pathogenesis of the disease, the Parkinson's disease. So that's why we do the research from the genetic and from the environmental toxin factors. So I think this is a typical Parkinson's disease shown in this video. You know the guy. The Hitler, he has a Parkinson's disease. So he has a typical bradykinesia of left hand and also typical the left hand tremor. So he is a Parkinson's disease patient. What is the cause of Parkinson's disease? Actually, we don't know exactly one cause or two cause. We just can conclude that this is an interaction between the genetic factor and the environmental factor. So if the genetic factor take the most important part, the onset age will get earlier. But when we see a Parkinson's disease, most of patients, their onset age is around 50 to 60. 50 to 60, but we also can see some patients their onset age is 30 or 40 years. So those patients has higher tendency. You can find the gene in those patients because gene factor is maybe play a more important role in this patient. So that's why we need to do the genetic research on the Parkinson's disease, and also the familial Parkinson's disease is account about 10% of Parkinson's disease population. So genetics is one of the important factors of the Parkinson's disease, causative and risk gene. So this is the summary of risk factor and protective factor according to some literature and also some epidemiology study. So you can see there's some protective factor, including physical activity and some other protection factor. So we hope we can at least, we cannot cure the disease, at least we can slow down the progression or do some early prevention. So that's why we need to do research to find out the biomarker and find out the underlying pathophysiology and the pathogenesis of Parkinson's disease. The heredity of PD is approximately 10 to 15% of PD has family history of other disorder. Genetic factor is in some patients is important. So in the genetic study, is starting from the 1990s. The first reported Parkinson-related gene is published in 1997 by Professor Polymeropoulos. He found that in some families, they carry the alpha-synuclein gene mutation, and this is autosomal dominant inheritance pattern. So later on, after the finding of the alpha-synuclein gene, he also found that the alpha-synuclein is present in the Lewy body. So nowadays we think Parkinson's disease is synucleinopathy. It's because alpha-synuclein problem, different from the other neurodegenerative disease. For example, like the Alzheimer's disease. Alzheimer's disease is because of beta amyloid aggregation. So Parkinson's disease is different. This is the Part 2. Part 2 is published in the next year, 1998, by Professor Mizuno and Professor Hattori. I just met Professor Hattori in this May in the World Congress of the Neurology. So this is young Hattori. This is, he is almost 60 years. And the Professor Mizuno and Hattori, they found a group of patients. They have Parkinson's disease very early. So this patient, he called it juvenile Parkinsonian. Those patients developing the Parkinsonian symptom around 10 to 30 years, so very early, quite early. And you can see the inheritance pattern. There's a consanguinity, and also the many siblings have affected in the same disease. So this is also somewhat recessive inheritance pattern. So this finding is also very important to contribute the PD pathogenesis. Nowadays we have found more than several Parkinson-related genes. The number is named from the PARK1 to PARK25. The blue one, those are autosomal dominant. So you can see the many cases are many genetic mutation. They presenting with the autosomal dominant Parkinson disease. But for the autosomal recessive, they usually have the earlier age onset. For example, like PARK2, Parkinson mutation, the age onset is less than 40s. And some related genes have been discovered in recent 10 years. So the molecular pathway of PD genes can be summary in this figure. They take a very important role in the cellular physiology, including the mitochondria function and the endolysosome transport system, and also the ubiquitin proteasome degrading system, and the mitochondria function, mitophage and autophage. So understanding the gene of the Parkinson genes can help us to solve the problem of Parkinson's disease. This is my previous research on the population in a Taiwanese cohort of Parkinson's disease patient. The age onset less than 30 years, we can find about more than two-thirds of patients, we can find the genetic mutation, including the Parkin mutation, PINK1 mutation, PAR2G6 mutation. In sporadic one, Parkinson disease, we also can find some risk mutation, including the LOCK2 mutation, GBA mutation. Those mutations can increase the risk of the Parkinson disease 2 to 4-fold. Regarding to the Parkinson disease, because it is usually late onset, so that's why in the late onset familial case is maybe more close to the sporadic ones. So the PARK8, LOCK2 gene discovery is very important in the Parkinson disease gene discovery. This is by the Payson Lewis in 2004. In LOCK2, there's a very, very important mutation because this mutation is highly prevalent in some populations. It's G19, 2019S. It's highly prevalent in North African Arabs and Ashkenazi Jews. So those patients, you can see the sporadic cases, they have more than 30% patient, they can find the LOCK2G 2019S mutation. In familials, also the more than 30%. But in Taiwan, we cannot find the LOCK2G 2019S mutation. The LOCK2, we only found the G2385R variant, genetic variant in the China, in the Taiwan, Hong Kong, and Japan, and Singapore. This genetic variant can have the earlier age onset of the Parkinson disease and increase the risk of Parkinson disease about 2 to 3 folds. So now we can use some internet tool. You can go to the www.ndsgene.org to search the current reported mutation. For example, the LOCK2 mutation, you can type the online and the system, the internet database can show you the distribution of different LOCK2 mutation cases. So it looks like cluster in the Europe and North Africa. And in Taiwan, there's 22 cases reported. The mutation is here. And because of the LAC2 G2019S mutation is very important in some population. So we want to know what is the function of this gene and what is the problem when the mutation occurs. So this paper we published in 2012 collaborate with the Professor Wang. He is also my mentor. We found that the G2019S LAC2 mutation can augment the kinase activity. So this is a gain of function mutation. So we can see the G2019S LAC2 transgenic mice, they increase the activation of the NKK junk pathway, and those mice can presenting the loss of dopamine neuron in 12 months and 16 months. And you can see the histology change and also the behavior change. And those mice, they are responding to levodopa treatment. So you can see here. So from this study, we successfully establish an animal model to recapitulate the LAC2 G2019S mutation and found the molecular pathway. This is through the activation of NKK junk pathway. So other researchers also found that LAC2 gain of function is very important for the Parkinson's disease. So in 2017, there's a first clinical trial for the LAC2 inhibitor reported, but now I think it's still in progress. Still not in market, but I think this is a good example. We found the basic research to transform to the clinical application. But I think not all the patients carry the LAC2 mutation, so it's only specific for some population. They carry the LAC2 mutation. So just like the cancer treatment, I think in the near future, we treat the neurological disease, neurodegenerative disease using the target therapy according to the specific problem, specific genetic mutation. We can design the specific treatment. So this is a potential treatment target for PD right now. So there's some clinical trials are underway. For example, some anti-diabetes medication, they found some neuroprotection effect, and some antisense oligonucleotide can reduce the abnormal protein aggregation to forming the Lewy body, and some medication can protect the mitochondria. And for the other PARC gene, PARC14 is autosomal recessive mutation for the Parkinson's disease. This is our patient is published in 2013. So this patient for the autosomal recessive Parkinson's disease, those patients onset very early. So this patient, when she take the video, I think so around 20 to 25. So it's quite early. So autosomal recessive usually has very early onset of Parkinson's disease, and some difficult treat. In some of those families, we found the PARK14 related mutation. In Taiwan, we found there's a mutation hotspot. It's Tu-Hsueh Yeh. This mutation present in many families, and also the mutation, heterologous mutation can be found in some sporadic patients. This is the clinical feature of the mutation carrier. It is presenting quite early. The onset age is 38 and 19, quite early. And also for autosomal recessive, we have 2 mutations. But one mutation can also increase the risk of Parkinson's disease and have the earlier onset. So in this study, we also found in sporadic PD patient, they carry the heterologous Tu-Hsueh Y mutation. They have earlier onset and increased risk of PD. What is the physiology role of the PAR2G6? PAR2G6 is a membrane protein. Membrane protein present in the cell membrane and also in the mitochondrial membrane. So it maintain the integrity of the membrane structure. So it's a calcium-independent phospholipase. And when it's activated, it hydrolyzes the SN2 ester bond in phospholipid. So it's maintain the membrane lipid homeostasis. So if the mutation occurs, so it can affect the cell membrane and also the mitochondrial function. So when we do the research, we start from the animal. Some experimental model or from the cell. Some experimental model we can do for the medical research. We can start from the cell line, then start from some animal, then finally we apply to human. Yeah. So in this study, we start from the cell line. In cell line study, we highly overexpress the different kind of PAR2G6 mutation in the HSY5Y cell. We found that in the PARK14 mutant, they have the impaired enzyme activity of phospholipase A2. So it can be explained why this mutation can cause the disease. It's because the phospholipase activity is altered by the mutation. So the cell membrane and the mitochondrial membrane, the membrane homeostasis and integrity cannot be maintained after the mutation. And also, so the mitochondrial function, we also found the mitochondrial function is decreased by the mutation. And the cell, you just can see on the plate, on the flask, on the culture dish. It's not real like real. It's just cell. So the next step, we want to do research using some animal model. So we use the zebrafish for study the pathogenesis of Parkinson's disease with carrying the PAR2G6 mutation. So in this study, we generate the morpholino knockout and also generate the transgene fish embryo to see the effect. So the behavior of the fish is altered when the fish carry the PAR2G6 human mutation. So the spontaneous coiling and the escape response is impaired in the fish, and also the degeneration test is we can find the neurodegeneration is present in the Pal2G6 knock-in fish, and but fish is not like the real human. So the next step we use the mammal system. We use the transgenic knock-in mice to do the further research. So this is a wild type Pal2G6 knock-in mice. This is Tu-Hsueh Yeh Pal2G6 knock-in mice. You can see the motor deficit of the mice in real time. And the locomotion and protest is all impaired when the mice carry the Pal2G6 mutations. Heterologous mutation are not affected. The homologous mutation are affected. So those mice also presenting with the neurodegeneration in the 9 months. We can see the decrease of the TH staining in the substantia nigra pars compacta. And also we do the VMAT2 density the image. You can see the striatal dopamine nerve terminal is decreased as well in the Pal2G6 homologous knock-in mice. So the Lewy body, we can also see the alpha-synuclein positive Lewy body in the brain section of the mice at the 6 months. And ultrastructure, we also can see the mitochondria impairment because we know the Pal2G6 is the function is maintain the membrane homeostasis and the integrity. So we did the electron microscope to see the mitochondrial membrane. So we can see in the mutant mice, the mitochondria integrity is altered, is changed. So we can conclude that the homologous Tu-Hsueh Yeh Pal2G6 mutant, it can cause the neurodegeneration and the Parkinson phenotype, and also the mitochondrial dysfunction, as shown in my study. And the other is PARK17 is caused by VPS35. This is reported discovery from the 2011 by Matthew Farrer. He found that in autosomal dominant Parkinson disease families, they found the PARK17 mutation. There are mutation hotspot is in the D620N. So we also generate a similar study using establish the knock-in mouse model, collaborate with Professor Wang and Professor Chu. This is we can see the D620N mutation. They are not affect the protein expression. This is not truncated mutation. So the protein expression is the same in the mutant mice. But in the 16 months, we can see the neurodegeneration in the VPS 35 heterologous knock-in mice. And also is present in the late onset PD phenotype and the neurodegeneration in the mice. And also the upregulation of alpha-synuclein and phosphorylated tau were also evident, showing the dopamine neuron loss and the degeneration. what is the function of VPS35? The VPS35 is a vascular sorting protein 35. So the function of a VPS35 protein is to transport, to select the specific protein to transport into the Golgi complex, and also the VPS 35, there's a retromer complex, including the VPS 35 and the VPS 26 A and B, and the VPS 29. These four compartments, they form the tube structure to transport the protein into the Golgi apparatus, and also transport the protein to the cell membrane. So they play an important role to clean the abnormal protein, and also play an important role to express the protein to, for example, like the neurotransmitter receptor to the membrane. So if the mutation happens, so this will affect the transporter role for the and then cause the subsequent cell degeneration and the cell dysfunction. But those genes, those are only present in a small number of families and a small number of patients. So the monogenetic, like the VPS35 or PAR2G6, those cases are very, very few. But there are many sporadic patients, they carry some genetic variant. We call it a risk variant. So those patients can including the alpha-synuclein SMP or tau protein SMP, and more than 90 independent GWAS risk signal. So the next is we think the Parkinson disease is not solely the genetics, can also some environmental factor included to for the pathogenesis of Parkinson disease. So the one most important is neurotoxins. Neurotoxins can cause the neurodegeneration in early stage. So when the aging process, the neuron, we know the dopamine neuron less than 50%, the patient presenting the PD phenotype. So the next step, we also want to see the interaction between the gene and also the neurotoxin. So this is also an important, interesting story for Parkinson disease. This is MPTP story. Maybe some of you may have read this book. It's the case of the frozen addict. This was written by the Dr. William Langston. In around the 1980s, Dr. Langston, he found that there are several patients presenting rigidity and akinesia, very like Parkinson disease in quite young age. So, and in the prison. So he further search. He found that this is because in 1980s there's some, the heroin, because the addiction of the opioid is quite great issue in the society. So, but the heroin is not easy to get. So some smart people, they use the chemical to synthesize the heroin to sell to the market. But unfortunately, when they do the synthesis of the heroin-like compound, there's an impurity of the chemical cause the MPTP. So when those patients inhaled the the chemical containing MPTP, they develop the Parkinson disease feature. This is because MPTP can through the NLB to convert to MPP plus. MPP plus is very toxic to the mitochondria complex 1 protein. It can destroy the dopaminergic neuron selectively because it's through the, you can see that it's through the dopamine transporter enter into the dopamine neuron. So that's why there's many, in the lifetime, there's many patients, they in the prison, they found that they have Parkinsonian feature. So this MPTP story. So that is also open another view to see is any possibility or any other neurotoxin can also cause the Parkinson disease. So in a study in Taiwan published in 1997, there's a Taiwanese cohort. They found that living in the rural residence and do the farming work and growing rice and also use the herbicide or pesticide and use the paraquat, they significantly increase the risk of the Parkinson disease. So that's also some epidemiology view of the environmental factor can cause the Parkinson disease. So also in the in U.S. and European and other Western countries, they also found that the big epidemiology study, they found the pesticide application is increased about 1.3 to 6.6 fold of the risk of the Parkinson disease. The paraquat is one of them, and rotenone is one of them. And organochlorine is also increased the risk about twofold. So that's why the environmental protection, I think, is very important in nowadays and in the future. So we should save the earth is save us. Save the earth is save us. Okay, so. Those pesticide, they found that the pesticide, some of the pesticide, the action is inhibit the aldehyde dehydrogenase. Aldehyde dehydrogenase is present, type 2 is present in mitochondria. It's converted to the dopamine, to the aldehyde, toxic aldehyde to the dopac. If the dopel too much, it will generate the free radical to kill the mitochondria and kill the cell, kill the neuron. So the pesticide, they found that they have some inhibition role for the LDH function. And interestingly, in the Asia population, in Taiwan, China, Korean, and Japan, our population carry the aldehyde dehydrogenase genetic polymorphism E487K. If you carry the homozygous variant, the LDH activity, LDH2 activity will decrease to 3%. For the heterozygous, it will decrease the activity for 20 to 40%. So in population study, so that's why in population study they found that for carrier LDH2 mutant, they can increase the risk of the Parkinson disease in conjunction with the use of some toxic, neurotoxin, for example, like pesticide. LDH is also an important enzyme to convert alcohol. So alcohol is another predisposing factor of the neurodegeneration. So in this study, we want to see if we correct the LDH dysfunction, can we rescue the neuron? This is because in 1998, there's a U.S. group in Stanford University. They found a chemical. They can increase the LDH activity. So we want to study, is it a potential neuroprotection drug for the Parkinson's disease? So we did this study and published in 2015. The hypothesis is the environmental factor and the LDH enzyme polymorphism, those are risks for the Parkinson's disease, causing the LDH dysfunction and generate excessive the toxic aldehyde. And the toxic aldehyde subsequently cause the neuron dysfunction, the neural death. So in this study, we found that the LDH2 mutation, they have decreased the function of the LDH activities. And in the rotenol-treated animal model, we found treat cell. We found the mitochondrial dysfunction is apparent in the LDH2 mutant, but when we treat the cell with the ALDA, this is the LDH2 activator. It can rescue the rotenol-induced mitochondrial dysfunction in vitro. So further this study, we also do the animal study. We use the two animal model. One is rotenol-induced the mouse model. The other is MPTP mouse model. We all apply the ALD. ALDA1 is LDH activator to see the effect for the neuroprotection. So in this study, we found that ALDA1 can ameliorate the rotenol-induced dopamine neuron neurodegeneration in substantia nigra neuron. So I think this can open another future to maybe we can some days we can find the solution to treat the in some patients. So also the pesticide pesticide is neurotoxin, can directly act on the neuron. It can also cause the neurodegeneration through the change of the microbiota in the gut. The gut can affect the brain, cause the systemic inflammation, and also leaky gut, and cause the metabolic endocrine pathway abnormality to cause the progression of the dopamine Parkinson's disease. So this is another study. I collaborate with Professor Huang. We want to see is any natural compound or natural product can present with have the neuroprotection role. This is a fruit I think in Southeast Asia. It's a mangosteen, 山竹 mangosteen. The mangosteen, the fruit is, they have many important roles, especially the pericarp. The pericarp can have some antioxidant effect. So in this study, we use the 6 OHDA-induced Parkinson disease rat model to see the effect of the treatment of with the mangosteen pericarp extract, and we also want to see the change of the gut microbiota. So in this study, we found that in the rat model of PD, by unilateral cis-out OHDA cis-out injection can show the gut dysbiosis similar to the PD condition. So you can see in the manganese treatment can found it can be recover the normal component of the gut microbiota in this study. Okay, so supplement is some reshaping effect by the mangosteen pericarp. And the study we also found that the RS and mitochondrial dysfunction is improved after the supplement. For that is a toxin-induced model. We can see the gut dysbiosis, but also in our VPS 35 knocking mice, we also can see the change of the gut microbiota in the knocking mice model. So we can see the alpha diversity represent the species richness and evenness remains similar, but in the alpha beta diversity is different in the wild type and the knocking mouse model. The PD group exhibit higher abundance of some specific bacteria, including the Odoribacter candidatus asomitus and Provotella. Those bacteria is more prevalent, more abundant in the knocking mouse. So there's a current some clinical challenge and unmet need in Parkinson disease from the diagnosis, prognosis, treatment, and to the some non-motor symptom. The diagnosis challenge is still there because in some patients they presenting with the TRAP. Sometimes we cannot make a correct diagnosis at the first visit. The first visit, the diagnosis accuracy of the PD is about 75% in the experienced neurologist. The misdiagnosis rate is as high as 20 to 30%. So in different stage, I think for treating the neurodegenerative disease, we needed to develop and the invention of different biomarker. From the preclinical stage, we need to found some risk biomarker, those including the diet, drink, and lifestyle. And for the pre-diagnostic PD, we need some diagnostic biomarker to differentiate different Parkinson disease from other typical Parkinsonian because the pathophysiology are different. And we need some prognostic and treatment choice biomarker for assist our selection of the future targeted therapy. So this is a study we have done in 2017. We used the human PD patient sample to do the proteomic study to try to discover some useful biomarker for Parkinson disease. In this study, we found that the RAP35 expression is increased in PD patient, but not in other Parkinson plus syndrome like multiple system atrophy or progressive supranuclear palsy. And the expression of REF35, we can see the age onset is earlier than the lower expression. So in this study, we further do the cell experiment to see is the REF35, what is the role of REF35 in the PD pathogenesis. So we use the in vitro model to express the A53T alpha-synuclein mutation, and found that the REF35 will promote aggregation of the abnormal alpha-synuclein in the culture dish. And we further do the clinical validation study to see combine the alpha-synuclein and REF35. This can be a better biomarker for Parkinson's disease. The study published in 2019, we found that in combination with the two marker, we have good prediction role for the PD, and can differentiate the PD from NSA and the PD from PSP. So let's conclude my talk today. The pathogenesis of Parkinson's disease is still a puzzle. There are several parts can cause the early neurodegeneration of dopaminergic neuron. The aging is a factor, and the impaired protein coherence and lifestyle, environment, genetic factor, alpha-synuclein misfolding and aggregation, mitochondrial dysfunction, neuroinflammation, those can get together to cause the early degeneration of dopaminergic neuron, then subsequently cause the resulting in the PD phenotype. So the future perspective for the genetic research, for the genetics test, it's just like sometimes it's just like the fortune telling. You carry the gene, you might have some chance to develop a disease. Yeah, so maybe in the future it can be a good biomarker for the early diagnosis and early prevention. This is Google co-founder Sergey Brin. I think you should know him because he is co-founder of the Google, and we use Google every day, and we go Google in many situations. He wrote a post in 2008. He is also support a genetic diagnosis lab called 33andMe. The 33andMe is the company is run by his wife. So he did the genetic study for himself. It's because his mother and his aunt, they all suffer the Parkinson's disease. So he want to know is he the genetic problem. So he did the genetic test and found that he carried the LAP2 G2019S mutation. But I think the important thing is to be positive to the finding. So he said, this leave me in a rather unique position. I know early in my life something I am substantially predisposed to. I now have the opportunity to adjust my life to reduce those odds. So I think keep the optimistic to this finding. And I think maybe in the near future we can develop some targeted therapy according to those findings to treat the patient. So, in our Chinese medical literature, in 2600 BC, the Huangdi he wrote the essay. The superior doctors prevented the disease. Mediocre doctors treated the disease before it evident. Inferior doctors treated the full-blown disease. So now we all inferior doctor. But I think that one day we can be a medical and be a superior doctor in the near future. Okay, this is application of clinical medicine in genetic research. You can do the counseling, encoding, writing risk, discovery of pathogenesis, developing any model to develop the preclinical trial. Okay, any question for me?